Hello and welcome to the Federal webinar. I'm S. Srinivasan. The Institute for Health Metrics and Evaluation, or IHM, housed by the University of Washington, in its recent projections has said that Omicron, the latest variant of COVID-19, is out to infect more than half of the global population. Now, coming to India, the daily infection rate, which is actually based on actual numbers, as of today is over 3.5 lakh. It is still shy of 4 lakh infections a day India witnessed in May 2021 at the height of Delta-induced second wave. But the spread of Omicron-induced infection is massive. It has attained 70% of the previous high in just 3 weeks as compared to a few months earlier. That's what I'm talking about, the second phase. Now, in the third phase, it has done in just 3 weeks. Therefore, the spread of the disease may no longer be described as a wave, but a torrent. But the indications are it might abate as fast as it arrives. Also, since it is only causing mild infections, it has given a sense of comfort to some. Some epidemiologists indicate that it is the beginning of the end of the pandemic and is slowly turning into an epidemic. But there are others who caution that it's a false sense of comfort. The virus has not done yet. It may still mutate and assume even more vicious forms. The vaccines, which seem to be the best weapon to beat the disease so far, is still inadequate in many ways. COVID-appropriate behavior is another shield humans could use to protect themselves, but it is practiced more in violation. Even among the well-intended, a sense of fatigue is settling in. But we need to open up schools, colleges, businesses, and restore contact-intensive services, as well as try to get the economy back on the rails. Therefore, is it safe or cynical to say that the public policy prescriptions today are resting between hope, providence on the one hand, and catch-up race between the science and the virus on the other? Therefore, we have framed a more moderate title for this webinar: Is Omicron changing the character of coronavirus into something less fearful? To discuss this, I'm joined by a panel of experts. I have with me Dr. Chandrakant Leheria. He's a public policy and health system specialist. He's a medical doctor and an author as well. He's based out of Delhi. I'm joined by Dr. K. Muganandam, an epidemiologist and infection disease specialist. He's a well-known face in Chennai. As a medical doctor, he has worn several hats. That includes being member of the Tamil Nadu COVID Task Force. I have pleasure in introducing Dr. Amitav Banerjee, a clinical epidemiologist and a medical practitioner. He's based out of Pune. Finally, I have with me Dr. T.V. Venkateswaran, senior scientist at Vigyan Prasad, an outstanding communicator. He helps Indian media with his innate ability to break down complex scientific issues into simple, understandable language. I welcome you all. I now request Dr. Chandrakant Leheria to begin with his observation. The house rule is simple. Each of the guests is required to make their opening remarks lasting over 3-4 minutes, following which we start our discussion. If time permits, in the last segment, we'll take up questions from the audience. Dr. Leheria, over to you.
Thank you very much, Mr. Srinivasan, and it's always a pleasure to speak at federal webinars. Starting on the main point, what we know when we are talking now is nearly 8 weeks since Omicron was first reported to World Health Organization, actually on 24th of November by South Africa. In the last 8 weeks, so we have learned a lot. What we have learned, that this is 3 to 4-fold more transmissible. The Omicron wave or the fresh wave is emerging due to happens in a very quick succession. 2 to 3 weeks cases rise, and then another 2 to 3 week cases decline. What we know that where it started or was first reported in South Africa, the fourth wave for the country is over. And this is based upon their data, which I looked yesterday only. So the fourth wave in South Africa is over. In other settings also, the wave which started has peaked. Coming back to India, by end of November or third week of November, or many of us were thinking that in 2022 we would have a new beginning and life would return to normal, but Omicron came as a surprise. What we know that the cases are rising in different settings. And of course, if India has reported 350,000 daily new COVID-19 cases, the number is definitely more than 400,000 a day, which was reported in second wave. The reason is simple. The country has changed the COVID-19 testing policy, and the testing policy does not recommend the testing of asymptomatic individual. Like before the Omicron wave, before 10th of January, India had a policy that every single suspected individual, anyone who is willing to get tested should be tested, which essentially was a test policy. But on 10th January, Indian government said that you don't have to test asymptomatic individuals in the community. But not only that, government policies say that you don't have to test the household contacts of the confirmed COVID-19 cases. And especially if we keep in the mind that 80 to 90% of the individuals who are getting infected with Omicron variant are asymptomatic. So with this kind of policy, when country is reporting 350,000 with the new testing policy settling in, this is a more than what second wave had witnessed in a day. Though number might not reflect that. Coming to this thing, what it means, the learning that Omicron cases rise very quickly, what is expected, and this is based upon modeling projections. Sutra and other models have projected that India might peak early February or mid-February, and the wave might end in mid-March. But also epidemiologically, we know that cases are rising very quickly. So India, in my opinion, will witness the peak in this wave would be very different from the peak in the previous two waves. In epidemiology, when we say epidemic wave or peak, it is it's a bell-shaped curve. It take to the peak and then start declining. But in this wave, in my opinion, it is going to be U-shaped curve. And when I say U-shaped curve, it means because of the chain testing policy, but India would have a three phase of this wave. Essentially, the major city or metropolitan cities had witnessed the rise, and then cases are falling in those settings. But what we are seeing, the second phase of the same wave, where cases are rising in urban setting of all the districts across the country. And by the time the cases would start declining in urban setting, there might be rise in the rural area. So these three things would mean that cases which have reached to like 300 or 350,000, these might settle or fluctuate a little bit, but this will be stay for a high for some period of time till mid-February, then it would start declining. What it also means that we should not be worried. We should not be paying attention merely to when the peak would arrive. This is immaterial in this wave because of changing testing policy. Nothing is comparable. We should not also be paying attention on what is daily new COVID-19 cases, or our parameter to track this pandemic had to be very different. But all I would say that this is definitely milder. The number of infection in the healthy or even those with comorbidity but vaccinated are mild. It's only those people who have a comorbidity who are at high risk, or unvaccinated who are at high risk. But most importantly, even the parameter of a number of people hospitalized in this wave is not correct. The reason it is not correct because majority of those who are hospitalized are incidental finding of being COVID-19 positive. They did not come to the hospital because of COVID-19 testing, but they were in the hospital and then they were tested COVID-19. So we need to have a really nuanced parameter. Final point I would like to make here, that is all epidemiological parameters say that the wave would end, at least in India, by mid-March or end March. And India can very well be in the safe zone after that period of time. The point here to remember, it will not be safe zone. Like if somebody say that it is because Omicron will result in that, I think that will be incomplete argument. Country would be in the safe zone for a combination of three factors. One is that it has a previous high natural infection, so the people have developed antibody. Then adult population has been vaccinated, and now Omicron surge is happening, and which also providing further antibody or protection. So all these three combinations will work in different form, and that's why India would be in the safer zone. Two last point. One, this essentially could mean, provided there is no new variant which is more transmissible, that India can prepare for endemicity stage. and each country would determine their endemicity stage in their setting. And the second and final point is that this is also a reminder that countries should not be in rush, to administer booster doses for rest of the population. With this current infection going on, the need for booster in healthy adult or anybody younger than 60 is very minimal. That decision should be put on for more scientific scrutiny or wait. Similarly, for children, there is no rush to vaccinate because of the factors I outlined. Thank you very much.
Thank you. I think you are saying that actually the goalpost itself, which was initially laid out as a management of the pandemic, is now changing because of the nature of Omicron. But another important factor you said is we are in a safe zone, provided there are no new mutations. Now, Dr. Banerjee, can you give your points?
Okay. Thank you, Mr. Srinivasan. And I agree with most of the points made by Dr. Lahiria. And I would like to go further, just to expand on it. And he very rightly said that the yardstick by which the number of cases and number of hospitalization does not hold good with the changing policies. What now we should reassuring for us would be in this situation would be that number of deaths are not very high compared to the number of infections. Now we are having 2 to 3 lakhs per day, and number of deaths are just 300, 400. And if you see the number of deaths in USA last 24 hours was almost 3 lakhs, 2 to 3 lakhs, I think. 2 to 3,000. And the cases were almost touching 7 to 8 lakhs. So, and the deaths were almost 2 to 3,000 in USA. And even in a small country like UK, were just 6.5 crores, they are having 300 deaths. We are having around 400, 500. So that should be reassuring. And another reassuring factor would be that our population cushioning perhaps because of a younger population. And as Dr. Lahiria said, we had a run of natural infection. Almost in June, we had almost 67% with natural infection, which gives, I think, an added advantage over the vaccine immunity also. Subsequently, we have rolled out the vaccination, and 80% of our young population below 18 also had antibodies. So that is also a reassuring thing. And about Omicron, this is the way nature pandemics, it's a natural history in populations. We have a natural history in individuals of a disease, and natural history in populations like the subsequent variants tend to be benign by law of natural selection, because those which are more virulent, they die with the host or they cause symptoms. And now with everybody is aware of self-isolation. So people they will self-isolate, so those virulent variants will not transmit further. So it is the milder variants which will have an edge in the evolutionary race, and it will now spread far. And fortunately, as we have seen, hospitals also, the average illness is 3 to 4 days or 5 days and very minimum hospitalization. So that should be reassuring, and that will act as a sort of a added antigenic stimulus for getting the immunity from the natural infection Omicron. And I agree with Dr. Lahiria that too many boosters now, because what is happening in our country, we have to see the environment also. We have seen the agent, we have seen the host factors, we have to see the environments are very crowded countries. We have got a very crowded, highly dense country. We may be getting repeated natural reinfection. And if you get boosters over that, there are certain studies which shows that too much of antigenic stimulation can cause T cell exhaustion. So firstly, that would be a waste of resources, and it may interfere with, there are a phenomena like T cell exhaustion, which has been reported now. So that way, I think we are favorably placed, and I would say we will, by first week of February, we should be past the peak. I am a little more optimistic than Dr. Lahiria. So anyway, thank you.
Yeah, nice to hear that. Now, Dr. Guhanandan, your initial remarks. I must quickly say, Dr. Guhanandan, even as a practitioner, has dealt with breakouts of several infectious diseases in the past, such as H1N1 strain in 92-93. Swine flu in 2009, H1N1, and Madras strain in 92-93. And he's also a member of the task force. Now, with all these changes happening so fast, Dr. Guhanandan, isn't it that you also have to re-strategize everything?
Yeah, mute, Doctor.
Yes, you're on mute. Yeah.
Thank you so much, Mr. Srinivasan. It's a privilege for me to discuss on this particular subject. I have been a practicing epidemiologist and also infectious disease person from 1987. I have been the director of Communicable Diseases Hospital, handled at least about 7, 8 epidemics and pandemics, at least 4 pandemics. I have been watching this pandemic right from the beginning, and as a task force member of the previous government in Tamil Nadu as well as the present government, we thought we have really referred back to the Spanish flu, which caused a very big havoc in this entire world. The number of deaths due to Spanish flu outnumbers even these present COVID infections. In Madras presidency alone, we had about 20 lakhs deaths in 1918. The epidemic lasted from 1918 to 1919, nearly about 2.5 years. Every year I used to usually have some outbreaks of viral diseases in Chennai and also in Tamil Nadu. Every viral disease goes to a peak and causes more deaths in worst circumstances, and it comes down. So the virus lives in the human body. In the environment, it is less livable. And now we have seen the highest peak of deaths throughout the world, and we have seen about 56 lakhs of deaths in the world. And in Tamil Nadu, we had seen about nearly 37,000 deaths. So we have gone to the peak of deaths, and it has to come down. The viral, my professors used to say the virus has got a dead end in human lives. And we have gone to the peak of the curve, and then it has to come down. It has already started. Again, there was a discussion about mutations, several mutations. My question to the scientist like Dr. Venkateswaran is, does these mutations causes the virulence increase in any of the past viral pandemics? That's my question. And here in this Omicron, it has mutated for more than 32 times. My inference is the mutation in the spikes only causes more of transmissibility in the community. Wherever the density of the population is quite high, it spreads very fast. And the entire pandemic of this COVID virus had gone virulent in the second wave with the Delta viruses, and then has come down, and the deaths also have come down. And it is now becoming an endemic illness like our common cold. To my opinion, even in the last meeting of the Honorable Chief Minister in the expert committee meeting, what I told was this is going to be a common flu-like fever because in flu, we give the vaccines every year, and even the flu causes more deaths among the people, especially elderly people and the people suffering from comorbid conditions. So the Tamil Nadu government should venture in testing people above 60 years and the comorbid and people who have got high symptoms. And other than that, if you are going to test everybody, it will go in lakhs and millions. All the positive people will be seen because it is spreading very fast. So this particular virus is going to be an endemic for the next for decade of years, maybe another 10 years, like what we have seen in H1N1 swine flu. It was in 2009. I was handling it for the entire state of Tamil Nadu. And it is still, we have some swine flu cases. From the pandemic proportion, it has come down to the endemic proportion in our own country. And it is very less in number. We are going to have more number of cases. So I'm sure this Omicron virus is not going to have a very bad impact than the transmissibility among our people. And of course, it causes severe body pain. I have treated nearly about 9,000 cases in my hospital, SIMS hospital here. Now we are admitting the cases. We have at least about 600 cases treated in the hospital in the past 8 weeks. And not even 5 cases have gone very severe. But few cases with comorbid, like our elderly people, 94 years old, 73 years old, they are kept for a long time in the hospital. But for that, everybody is getting discharged. I have been discouraging my doctor not to admit more number of patients unless they warranted because of the age and the cofactors like NCD and other things. Because you're out of fear about with the past experience of the epidemic, everybody comes to the hospital and seeks for admissions. In Delta period, people used to book for the family members the rooms in the hospitals. So that situation has gone. So the responsibility of the government is not only picking up all the public health preventive measures. I've been a field worker for nearly about 20 years in the field community, and I have been suggesting the government to make stringent procedures about the preventive measures, identification, isolation, home quarantine, screening at the airports and in the railway stations, and the schools and the working places. And the lockdown also we suggested on Sundays, because every cluster started from the malls and the markets, the fish markets, vegetable markets, and at the night lockdowns. But for that, let us not hamper the life of the people, because Chennai, like metropolitan cities in India, since I worked at the national level also, almost all the metropolitan cities have got 1/3 of the population is slum population, who are all daily wage people. During these 2 years, the sufferings of the people were untold stories. People had no food, no work, and even in the IT sectors, people were affected. It has hampered the life of the people. So I requested, the first request I made to the Chief Minister was, kindly don't consider about lockdown like previous periods, number one. Number two, let us test the people who have got highly symptomatic and then 60 years plus, and people with comorbid conditions. Let us be very careful about the elderly, because not only COVID period, but even in the previous years, if you take the data, health data, in Chennai city, I have taken this data. Even in the previous years during this seasonal flu, people suffering from other illnesses, they suffered lots. The same thing is happening now. So it is turning out to be a common cold, and then the international agencies in Maryland and other places, the vaccine technically modified vaccines are also being developed, and then this will be again added to our quadrivalent vaccine, which has got 5 types of viruses, which has to be given every year. That is going to be an issue. And again, I have been telling the government, we should not withdraw the intensity of our pressure on the community about masking, hand washing, social distancing, and then physical distancing, and then mouth washing. All these things we have been telling. And again, other point I would like to raise, maybe it is the right forum to tell that also. Almost in the history of the world, the development of the public health or the health system were always been during the epidemics. I was a student of London School of Hygiene and Tropical Medicine. We usually read these stories of history of the epidemics, and really we are delighted how the young doctors have really came up with a lot of research and innovative methods for developing the system. So I told the government, it is the high time that we realize, not only talking in seminars and in Zoom meetings about the virus and other things, but also the system, because the doctor community and the field workers were stretched to the maximum in the past 2.5 years. The fatigue stage has occurred. People are really bothered. And are we really pressurizing the government to fill up the places, vacancies, fill up the system, improve the system, laboratory system, diagnostic system? All these things are to be really stabilized. I think we are really missing the opportunity of developing the system. I think I will really suggest Srinivasan, we can organize a national level program meeting how to develop the health system. The health system learned a lot out of this epidemic, and it is high time how to improve the bedding, hospital manpower, and high technologies, and then communications, counseling, and then comorbidities. All these things are to be really put in shape. And I think we are only doing a firefighting, like what we do during usually the Indian style of handling floods and fires. That is what we are trying to do, but we are not really waking up ourselves to improve the health system. I think with this, I just started. Maybe when questions are raised by Srinivasan, I can definitely answer that.
Yeah, thank you very much. I think you have made very valid points. Actually, I was going to raise some of these questions. Certainly, we'll come back to that. First, let's hear what Venkateshwaran has to say. I think here is a straight question for you. Whatever you thought earlier in your opening remarks, you must include this. Is it Omicron mild or deadly?
Yeah, very nice. So let me start with one comment about fear of public. Way back in 1930s, the study on public reaction to public dangers, like earthquake, was done in India. One of the pioneers, international pioneer, is a person called Jamuna Prasad. So what he pointed out was that we fear when things are unknown. That is, when people were saying that there is going to be an earthquake, there was more fear than after the earthquake occurred. And the fear was much more in the nearby district rather than in the place where actually the earthquake occurred. Because once we have experienced, a little amount of our fear goes away, and perhaps maybe sometimes we are also foolishly, let's say, confident that nothing will happen to me. Okay, so that's a part of it. So we have less fear today because we have lived through this pandemic. I mean, we have survived this pandemic, so we are less fearful. But I think we have to be continuously alert. We should not leave our guard. Being fearful and being alert are two different stuff. There is no need to be fearful, but we need to be alert. That's number one. Number two, I think we need to look at this virus specificity and the way, for example, immune responses take place. If you look at this virus is able to affect both the upper and the lower respiratory tract. And antibodies are good in circulating in the lower respiratory tract, but not so much in the nostrils, the linings of nostrils. So what can happen? I mean, what we are also seeing in Omicron is the same thing. If you are vaccinated and possibly if you have had past infection, then you don't get into a serious illness because by the time the virus is attacking your lower respiratory tract, like your lungs, your antibodies are able to arrest it. But the infection per se at upper nostrils continue to happen. Okay, so this particular character we need to keep in mind about this particular virus in whatever long-term planning that we are thinking of from now on. But one thing is very clear in India. If you compare the so-called second wave, when we had the number of cases, the kind of cases that we are having today, like 3.5 lakhs per day, etc. That time we had about 4,000 plus deaths per day. Today the deaths are about 400. Even every death is, a sad situation. But still, you can see that the number of deaths are very, very low. And quite obviously, this time the reporting of actually infected people are also very low because many people don't even test because they are not feeling any discomfort. 1 day, 2 days, they are all okay. So what is very clear is that vaccines have helped. So people who have not taken vaccine and still fearing vaccine or having hesitancy for taking the second dose, my view would be that please do take it. Okay, it protects you from death. Vaccines generally give three kinds of protection. One is protection from infection. One thing that we know from the experience now is most of the COVID vaccines does not give you protection from infection per se for all people. But all vaccines give you considerable protection against serious illness, considerable protection against death. Right? So it's important that we don't get into serious illness or death because long COVID is a big challenge. I mean, your different parts of your body can be affected because of this COVID. Now, let me come to your question. Is Omicron mild or, scary? In a country like India, where we have had a substantial vaccination by now, I think we are very, we can just brush it away by saying that, oh, it's mild because even though we have so many cases, only so many deaths are happening, beds are not occupied and so on. But if you look at all over the world, there is no equitous vaccine distribution, right? So in countries where enough vaccination has not happened, a variant like Omicron can generate even more deadlier variants, which can come with much more mutation and which can reduce the effectiveness of vaccines even in places where there is vaccine. So one public health goal internationally is, I think, to ensure that all over the world, the vaccines are made available as early as possible. This, I think, is an important issue. Although it may not be the concern of Tamil Nadu per se, or we may think in that fashion, but one thing this pandemic has told us is that if you have to be the world has to be fine. I mean, we alone cannot survive. That's something that I think we have to learn from this COVID. That's one thing. The variants emerge when there is a large number of people are infected. So even a variant like Omicron, which is not causing so much of death, if it actually reaches very large numbers, then more variants emergence possibility will occur. Let's look at, for example, the Spanish influenza that Dr. Guhanandam also mentioned, that happened about 100 years ago. In India, there is an estimate that about 5 crore people died out of about 30 plus crore population in those days. Right? It's a very, very substantial death. Now with this COVID, we have about 65 lakh death all over the world. Right? So compared to that, because of our epidemiology knowledge and vaccine rollout, we have been able to restrict the death to a great extent, including lockdowns and things of that kind. But still, we need to remember the influenza pandemic occurs once in a while, and roughly about 6 lakh people die all over the world every year because of the influenza. So So similarly, the COVID, because it's a respiratory disease and humans are reservoir, and influenza, we are not able to put any vaccine because it's a very highly mutating virus. It was not very easy to get no vaccination all around. But if we do substantial vaccination all over the world, then even long-term impact of COVID can be suppressed. That's, I think, we need to keep in mind.
Right. I got your point. Since you're a scientist, I still want to know the science of it. See, the thing is, you said, I do agree that upper respiratory, diseases are difficult to cure, and you don't have even a common flu. It's tough to control that. I do agree that there is a problem, but scientists have caught up quite a bit in the last 2 years. There has been a combined global effort to put together a vaccination. I think it's one of the fastest effort ever that has happened. But still, is a catch-up over? Are you confident that this particular Omicron is? Are you kind of considering this is the last of what you would be seeing? Here it's again your entire vaccine. Correct me if I'm wrong, is largely based on spike protein. Have we been able to find other kinds of vaccines which can wholly attack the core of it? I'm asking this question as a layperson.
Yeah, it's a very good question. In fact, slightly, I may seem to be differing from some of the panel members in the emphasis. I generally agree with the general trend. There is no need for the so-called strict lockdowns and those kinds of public measures. They are not going to be helpful. But Omicron is not something that we can brush aside as mild and then just sit. That's my view. This is not the end of it. As I was pointing out, there is reservoirs of human beings who are still carrying this virus in places where there is no vaccination, where this can also emerge into a new variant, which can even cause another pandemic wave, even in places where there is vaccination. So number one. Number two, spike protein is what we focused for vaccines, almost all vaccines. Except the whole variant vaccines, essentially because that's the only way the virus will be able to get access to our cells. If the virus cannot enter our cell, the virus cannot reproduce. If it cannot reproduce within a short time, the virus is become ineffective, right? So it has to enter our cell to reproduce. That's basically the infection and disease. That's how it happens. So if you can arrest the entry, then you will be able to restrict the disease and infection. That's why spike protein is concentrated. Even if there is mutation in other parts, if the vaccine is able to arrest the spike protein, the vaccines will still work. But the question is that the spike protein itself is changed. The genome of the spike protein itself is changing. How far it will change, how much it can change, we don't know. For example, measles vaccine is targeting one part of the genome. What accidentally we found out. I mean, we didn't know that when we were developing the vaccine, but later we accidentally found out that accidentally we have chosen a place in measles genome that even if there is a change, even if there is a little change in that area, the virus will no longer be viable. So accidentally we have chosen a right spot to develop a vaccine against measles. But in COVID, how far the spike protein can change further, can become immune escape, is something that we don't. The point that I was also pointing out about upper respiratory tract is, even if you are infected, even if you had vaccines, even if your body has threshold levels of antibody, the antibodies work in lungs much faster, much stronger than, for example, in nostril. So getting foothold for this virus is easy.
Right. Right. Thank you. Thank you. That's a good point. Dr. Lahiri, I'll come to you. You have seen several vaccines. This is not the first vaccine. You have studied other vaccines as well. As far as vaccine development is concerned, we will devote this particular section more on the science of it. So, I'm asking the same question to you in a different form. How are you kind of from your opening statement, I could see a certain sense of optimism. You said that we are entering a safe zone, but then you had a caveat there, provided there is no new variant. Now, how do you ensure that this provided word is minimized?
Well, there is no way that this provided can be minimized. That's a given. But then we have scientific backing to say that a future variant is less likely to cause a major impact than more likely. So the scenario is this, that when the variant would emerge, this is a large RNA virus, 30,000 base pairs, mutations are normal, virus even in the post-pandemic period, endemicity virus would keep circulating and RNA virus keep mutating. So that's the given thing. Now, what is going to happen that this ultimately a mutation will bring variant. It will not bring a new virus. And variant essentially convey the point that immunity provided by natural infection or vaccines would not be fully effective, but it will still be effective. Now, we don't know how much effective it will be, whether it will be 95% of the original or 70% of the protection. And that is a given thing. But in the last 2 years and a time ahead, natural infection, vaccines, and then Omicron surge, which is going to infect, in my opinion, a large proportion of population in the settings where it will go. In India, by the time Omicron wave would be over, it is possible that 50 to 70% of population will be will have infection, and in addition to whatever they had. So any new variant which would have impact need to have a really high transmissibility and need to have a high immune escape, and both together are not going to happen. But what is going to happen in a possible scenario from an epidemiological perspective, I often give this analogy, and then many other people use this analogy, so I don't own this one. But this is scenario like a cyclone. So if you are living in coastal area like Odisha or some other parts which are near the sea, and in those areas, if cyclone comes, even then you don't leave that area. So what you do, that if there is a cyclone alert, you get ready for it, you prepare for it. Once cyclone is over, you start living normal life. And that is what is a likely scenario for SARS-CoV-2. That in most likely things would be normal. But in a scenario, there is a risk of a new variant emerge, then you will again go into that mode of response. And then once that wave is over, you will start living normal life. So those cannot be ruled out, but we have to take a cyclone or disaster analogy to respond to this wave. That's one. Second part is that I personally think, and my work on vaccines, like I studied vaccines immunology, I personally, like we are hearing a lot that many of the vaccines are new, like new platforms. Of course, on those platforms such as mRNA or viral vector, those are the first vaccine. But those platforms are not new. They were under development for 20 years or 25 years. So they are an older platform. That's one. Second thing is that these are the first generation vaccine. That's a normal process in science, that you develop second generation, a better vaccine, which will be more inclusive of other variants. There are dialogue going on pan-coronavirus vaccines where scientists are discussing, and this is a possibility because of new platform. Scientists are discussing that not only the existing variants are covered, but by use of artificial intelligence, scientists are working to predict what are the likely mutation in which part of the spike protein, and then you prepare for the future variants also. So pan-coronavirus variant vaccines are not something distant possibility. They are very much possible. Final point here is that what some of the evolutionary virologists keep saying, and this is one of the virologists from Australia who was also the first one, along with the Chinese scientists, to sequence the entire genome of the coronavirus. So she said, this evolutionary virologist said that the virus would mutate, and it is likely that 10 years down the lane, we might have a SARS-CoV-2, which would be very different from the original strain which was picked up. What it also means that the future vaccines also need to be rapidly changed, or maybe the minimum is that the future COVID-19 vaccine or SARS-CoV-2 vaccines would have at least 2 strains within it. So there is all the possibilities. But key that we will be out of the pandemic, I am fairly confident. The only other thing is that even with the emergence of new variant, we will be out of the pandemic. We will handle that. The only thing is, in my opinion, the endemicity would settle in every country at different point of time. And there would not be a global parameter to say that this is the number of cases, then only we will call it endemicity. Each country, depending upon their surveillance system, depending upon their natural infection vaccine coverage, will have to arrive on a consensus that this is the acceptable level of new infection in our setting, and we declare this endemic, and then you return to normal. Of course, some intervention need to be done. High-risk individual need to be protected, based upon local epidemiology. But nothing is going to happen in the pan-country. Nothing is going to happen even state-wise. Maybe in a district, let's say, Tamil Nadu, Tiruchirappalli, or somewhere cases are rising, you pay attention on that population, or in Ahmednagar in Maharashtra, or Bhopal in Madhya Pradesh. So it is going to be, future is going to be very localized intervention. I'm really optimistic after this wave that for India, we should not declare, no country should declare pandemic is over. We should be in cautious mode, but India would be in a situation where we can say that this is what looks like an endemicity for future.
Right. Thank you very much. I think you made some very important points, and that really threw a new light. I mean, the use of artificial intelligence, because we have a massive data available now, but it's a different question how much the data, how it is collected. I'll come to that because we may need an entire session on that, the way the data is collected, including even the counting of deaths. No, I'm not going into that. That's a big area. Because data gathering, now I think it's almost been given up now, because in this spread, I don't know, since the whole thing of triple treat, the contact tracing, testing, and treatment, I don't know whether even that's now quite a change, because Dr. Guhanandan said testing has to be selective. It need not be mass. I think it's very interesting we are getting into that, but I just attempted to ask one question to Dr. Banerjee, taking from what you said. You said, the vaccines, second generation will be far better. That's very reassuring that we are learning constantly. And within 2 years, if we could do that, the second generation will be even better. That's very good. But, this as a public policy experts, all of you emphasize on averages. What I can call is the tyranny of average. When you leave out that 5%, 10%, and then say efficacy is this much, now what happens to a really vulnerable? Because as numbers in a large population, like you said, in 7 crores, it's, in a 7 billion population, 65 lakh death is very, compared to what happened in the previous epidemic, it's actually quite small. But then if you look at individual cases, it might look very big. That's what I want to know from Dr. Banerjee. How do you look at that?
First, a little correction. I didn't talk of second generation vaccines. I think it was Dr. Laharia.
No, I quoted him only. Sorry, did I say you? Yeah. No, Dr. Laharia said that. I'm saying, sorry.
Yeah. Anyway, as far as vaccines are concerned, it has been a bit of a disappointment. If you see that it was that once we get vaccine, we'll go back to normality. Now, some of the most vaccinated countries are seeing surges. I mean, Israel, you are saying they are going for 4th boosters, and Netherlands for 5th boosters, and that also now they have given up boosters because, as I said, of T-cell exhaustion. There is a published paper, peer-reviewed paper, which shows that they have done studies correlating vaccination levels in population. 68 countries and 2947 American counties. They did not find correlation between population level vaccination coverage and decreasing trend in incidence or fatality from COVID. So this is quite a humbling experience. So vaccine, even now the WHO and other bodies are also saying that we cannot vaccinate ourselves out of this pandemic. It is a fight between our technology and nature is always one step ahead. It is just like chasing a deer in the jungle. Deer will always run faster. It will mutate faster. And as it is, so we should now, this is the time to pause and think whether we require to have focused vaccination, as you said, the vulnerable, the people with comorbidity and elderly, or to go for mass vaccination, because it is not working. As the data, if you analyze the data properly, epidemiologically, mass vaccination is not curtailing the spread of the pandemic, and there are concerns by some eminent virologists that sometimes the vaccine pressure itself promotes mutations, because that is a concern. It is something like giving incomplete antibiotic or indiscriminate. And so we have to now really take a pause and think. And we now Omicron, it is 10 times less lethal than the previous variant, Delta. In India, even with Delta, if you see the Sero survey data, 90 crores people got infected after the second wave before the vaccine rollout, and only 3 to 5 crore were identified. So we missed 95. There was a large number of subclinical infection. And if you calculate the infection fatality rate, it is coming to 0.05% or 0.08% in the second wave, after the second wave. If you make it 10 times less lethal, this is the Omicron. So it is, the lethality is almost like coming down to common cold. And talking of common cold, even at the start of the pandemic, they did a studies. They found that even the common cold virus, if it attacks the nursing homes, because initial data and modeling were done from the Western countries like Italy and European countries, that even if the nursing homes are attacked with common cold, those who are infirm and very elderly, the mortality even from a common cold virus, viral infection is almost 8%. So hospital mortality rate in the elderly. So this Omicron is killing, or even the initial variants were killing 5% people in nursing homes. So that way, if you see, now it is coming down to the level of a common cold, and particularly a poor country like us, whether we can invest everything on a disease which has got so low mortality, particularly among a young population, at the cost of other health priorities. We have got so many other communicable diseases. Like, I mean, it is likely shifting from the topic of Omicron, but the thing is whether the Omicron still should get the royalty status which we gave to the, it is a descendant of an earlier more virulent virus. So what about other competing here? We have got this dengue fever, we have got measles, we have got so many things. Whether, I mean, these are just my public health. As a public health policy maker, I have to see other diseases also, whereas a scientist or clinician specialization will see one particular disease. So these are my concerns which I would like to be addressed.
Right. Dr. Gwanandan, you mentioned earlier about that it was such a great opportunity that we should have strengthened our infrastructure. Even actually, there was perhaps I think it was you who advocated there should be at least one testing center per district. There are 732 districts. There should be quarantine centers in all the medical colleges, both public and private. Barrier nursing practices, negative pressure rooms in all hospitals, sufficient ventilators, related gadgets, other critical care equipments. Do you see any change in these 2 years? I mean, I'm sure that people have understood more medical terminologies today, but has the hospital infrastructure kept up to that? Because I'll give you one small example. Genome sequencing. There's a recent report that they had to close down 5 centers because of lack of supply of essential ingredients. Actually, probably it's a way to say that it wasn't funded correctly. I'm not even coming to the union budget. I'll come to that later. Are we doing enough?
Right. Thank you for making that point. I have two answers to you. Number one is, with the due respect to all the international health agencies, I yet to know which agency guided which country properly in handling this epidemic is a big question. In public health, we say data makes you to take right decisions. Data helps you to take the right decisions. All the countries individually suffering a lot in handling this. For example, India and Italy and Iran, everybody suffered a lot, and everybody handled these cases only with the basic fundamental public health norms. The laboratories, they made lot of you and cry with the researchers that this is happening, this mutation is going on, all these things. With the due respect, that is good. But how it helped us to curtail the spread of the epidemic or the pandemic, to cut down the pandemic? Have we? Did they have any impact on the driver of that pandemic? No. That's why we say in public health, data helps you to helps you to take correct decisions. And again, the evidence-based methods that we followed in almost all the countries have helped. Some international agencies said testing is not required, this is not going to be harmful, this is very bad. All these controversial statements came from different parts of the world. But fortunately, India like country was so good that we were sticking on to our basic norms of the public health. And throughout the country, we followed the norms and we were able to do that. Again, I tell you, Srinivasan, the epidemics always strengthen the health systems. You said about, I have been raising this issue about negative pressure rooms, barrier nursing systems, oxygen facility, beds, ICU, all these things, zero delay admissions, all these things we are doing. But we are doing on a very random procedure or a firefighting procedure, but we have not established a system in our country in the health system. This is what we have to do, what we have to learn from this epidemic. This epidemic brought in a lot of things. For example, I really endorse Dr. Venkateswaran, who said this vaccination definitely helped us a lot. As a public health person, I know only two things. That is one, evidence-based management on the epidemics or the pandemics or the endemics through our basic fundamental public health norms. Number one. Number two, our next greatest weapon is vaccination. The vaccination we found, fortunately, the international agencies brought out very good vaccinations like your Covishield or Covaxin, which helped me a lot. In my own experience, I had seen in this city of Chennai and in the state of Tamil Nadu, the number of patients who got the vaccination suffered very bad illness are very less. The question again is whether the vaccination is useful or not. Vaccination is definitely useful because it has not taken the elderly people or anybody to grave morbid state. But again, I refer back to Dr. Venkatesan. This infection will be there found with the vaccinated people because our professors used to say what there is. Devanayagam, there is one pulmonologist used to say, the virus and the bacteria always lodges in the nostrils and the throat, even if you are vaccinated, like a dust. I have tested people, my patients who are vaccinated thrice with a booster, and the sample shows positivity for the coronavirus because the virus found in the nostrils and the throat are removable, that they are there. But the impact that is going to give in the internal system is going to be very less. That's why the people who are vaccinated, even if they suffer from the illnesses, they face only like a common flu like fever, and they never gone to the suffering like lung disease and all that. So we have to stick on to the vaccination. Very important. Vaccination helps a lot. Even among our group, our own educated doctors and the scientists, we should keep on pushing this idea of vaccinating because vaccine, I know how it is useful, how it has saved millions of lives during the smallpox, during cholera, during H1N1, and again in corona. So let us not bring any controversial statement about the vaccines. Whenever you test for neutral antibodies, when it is not found even after 2 vaccines, we suggest only for a booster dose. Because even in the flu viruses, we are giving the vaccination every year.
Yeah.
So scientifically, we have to go for booster doses. Maybe it will be linked to yearly vaccination also. And again, we will stick on to the basic norms on the public health preventive measures. And then again, strengthening the health system, especially public health system, which is cost effective.
Right. Yeah. Thank you. Dr. Venkatesh, here's a quick question. You see, you earlier, I may be forgetting, somebody said here that long COVID is less understood. It's not completely, it might have occurred because one reason is reactivation of dormant virus. Another is some microscopic clots that form after the infection, or there are other host of other possibilities. There are many reasons. But a large number of people still seem to be suffering very silently because they get very vague, feelings, and it lasts for quite a while. How do we deal with it?
Yeah, I think before I come to this question, I know that there is short of time, but I just want to make a point. I had looked at this paper that Dr. Banerjee was mentioning, and I would like to underscore that this multi-country study paper essentially looks at infection, not hospitalization or death in terms of vaccine. And of course, now we know very clearly that none of the COVID vaccines are able to prevent infection. That is clear, and that is also now. There is a why it is so. Also, kind of now we are able to understand because we know that if the protective level antibodies are not there, threshold level is not there. The infection can occur, and then it will take some time before the infection is able to be cleared, and it doesn't become lethal. That's just a point that I just wanted to place on record. Coming to your question, there are some 2-3 issues here. One is one of the study conducted in India itself showed that the COVID infection can affect even brain regions of brain, different parts of the body, different organs it can affect. So we need a much more systematic study on this, which I think nationally and internationally is not adequately done. We are right now concentrating only on people who are recovering and then going back home. But after they go back home, what happens? I think it's time that we also pay attention. There are people who complain that, young women who complain that after COVID, after even vaccination, that there is some, their periodicity is affected and so on. So some of this may be merely, a kind of a feeling, a false association, but some of them may have some deep information for which we need to have studies, which I think is lacking. But few things which we know from animal studies and other studies is that COVID does affect not just lungs, but different parts of the body, because it can seep through lungs to blood, and through blood it can go to places wherever there is a ACE2 receptor. Many other organs can get affected. So we need that kind of a study and some kind of a surveillance of people who are recovered from COVID, because long-term support might be needed for some people.
Thank you, Dr. Venkatesh. There is a small video which the producer wants to play about 8 column. Let's look out for that. Okay. Yeah. Okay. Thank you very much. Now, here is a question. anyone who wants to take it, Dr. Laria, if you take it, will be better. See, all the ground rules of management of COVID seem to have changed, whether it is testing, whether it is even the question of herd immunity. We are now not hearing much about herd immunity. So what is the way forward? Should we be opening up gradually, or there is an example, Britain has done it something very drastic. It has just opened up everything.
So as far as question like of changing strategy is concerned, what we need to remember that in the pandemic, especially with the time, the strategy need to be modified according to the newer understanding. So that is very given. Like people fail to understand that countries are changing strategy, but that is how it should be. That's what the public health principle is. That's one. Second is that, of course, we heard a lot about herd immunity, but my sense is that like the concept one is this is a virus which keeps changing, then the immunity does not last long enough to reach that threshold. So all those concepts are not applicable. But more importantly, in today's world, a country cannot say that it has achieved herd immunity. Its entire world is one single herd. So unless it is achieved something at the global level, and that is not going to happen, we cannot really think of herd immunity. So the idea of herd immunity propagated by some is definitely something which is not applicable in my opinion because of factors I outlined. Now coming to the countries, how a country should respond and responding. I have been writing about this a lot, that in epidemiology, there is one thing which matters a lot. It is a context. It's not like if United States is doing something, or Denmark or Sweden is doing something, India should do. If that were the case, if context did not matter, then the entire world would require just one technical expert group. They would keep guiding. But we need technical expert group in every country, every setting, because context matter a lot. And India's context is very different. So what UK is doing, like as an outsider, I would say that in this pandemic, UK had done a lot of back and forth. They opened everything, then they closed everything, and then they opened everything. So their approach is little erratic, in my opinion. As far as India is concerned, I think in this third wave, India's response from the epidemiology public health perspective has been really balanced. India, South Africa, some of the countries, low middle income countries, had done far better. Other settings have medicalized the public health or medicalized the pandemic, and the focus on treatment, vaccination, boosters. Like they were literally counting the amount of antibodies, which is a medicalization of vaccine, which is a public health intervention. So that is challenging. How it will open? I am very optimistic. Like South Africa, the scenario is South Africa, they had a cutoff of a certain cutoff that 5 per million number of new daily COVID-19 cases would reach, 5 per 100,000. Then they would call it, that's wave is over. And for them, this wave is over and things are opening up there. And that's similar situation in India. Like in India, things would open up. We should use local evidence, local data to arrive on conclusion and decision. There is no role of restrictions, literally no role of night curfews or weekend curfew. So all of those things are there. Things would open up. Like I foresee that Delhi, Mumbai, some other cities would open up. But as I said earlier, there would be 3 different short, merged phases in this wave. So one would end, other places would start showing cases. That's why we would see a high base, long base of U, inverse U. But things would be opening up. That's what I foresee. And of course, the caveat, the public health expert should always, and especially always speak with the caveat, like economists. If you ask economists a question, they would say maybe. The same is true for public health expert, that maybe if there is no variant and there are some unknowns. But at the same time, the final point is, in pandemic, ask public health experts or epidemiologists, because they are trained to make inference based upon the limited information. Of course, the claim is not about that you will be always right, but who can make decision based upon what is available. Thank you.
Yeah, thanks. Dr. Banerjee, here is a quick question now. What has become very important is, how do we reopen our schools, public places, businesses, other contact intensive services? I mean, there has been a debate, especially about schools. the state governments have been going back and forth on that.
Schools could be reopened because there are some countries which did not close the schools, like Sweden, and they didn't have any high morbidity, mortality among children. Secondly, in this, we should not be obsessed with the case count. Firstly, these some of the definition of cases is very questionable, like just having a RT-PCR positive should not be a case and raise the panic level, which has been happening from the beginning. So never we are having so many commensals. I can pick up staphylococcal, I can pick up streptococcus, and I can pick up pneumococcal. So those we do not say as cases. So I would say this has got a very special treatment, that firstly, these do not become cases. And rightly now we are going only for the symptomatic cases. Only symptomatic cases should be labeled as cases. So we should not open school, and after opening school, we should not start testing the school children. That will again cause panic, because it spreads to them and it settles very fast. So first mistake we have done was the labeling anybody with a RT-PCR positive, we are labeling cases, which is incorrect. Secondly, anybody dying with a RT-PCR positive, maybe dying of 3 or 4 comorbidities, were labeled as death due to COVID. So that's another mistake we made, which inflated or which just made the statistic very hazy. Even recently, CDC director said the 75% who died had 3 to 4 comorbidities. So that was something which is very, very alarming, labeling everyone who dies of fear. And school opening, I don't think school opening is going to cause any surge. We can have another session after this Omicron is over. I think after the Omicron runs through the country or runs through the world, the way it is going, there will be more stability, and we should never go for one different mistake the world public health community is making, is trying to achieve a zero COVID policy, which is becoming counterproductive. Australia is trying, it is boomeranging, and zero COVID possible. We should not go, because it's a disease where mortality is less than 0.01. With Omicron, it would be less than 0.01. So as I said, we should weigh. As a public health person, I am concerned about child malnutrition. It has increased in the recent UNICEF report. As a public health person, I am worried about the dengue situation. I am worried about the Japanese encephalitis, about the malaria situation. So we should not be obsessed with one disease and zero COVID. The world has gone into an obsessive compulsive disorder only around COVID, which is causing more harm than it is not able to. We are chasing a mirage. That's all.
Mm-hmm.
Yes.
Okay, that's a good point you made. I want to come to Dr. Guhanandan. You see, underfunding of public health services. It was promised that as a percentage of GDP, currently it's about 1.1. Before the pandemic, 2 years ago, it was 0.9. So marginal improvement, I would say, as a percent of GDP, national expenditure, public expenditure on health. Now, the promise is by 2025, it will probably go up to 2.5%. The thing is, if you include private investments as well, it's actually private investment multiple of public investment. But then the private investment goes in setting up hospitals, but their treatment are not more public oriented. It's more selective and curative, profit oriented, and all those kinds of things kick in. When do you think, or how do you think the government should go about it? Because the promises are being made, but we're still not seeing any light.
That's why, Srinivasan, I told you, we are missing several opportunities that we learned out of these epidemics like this. The entire global level health authorities strengthened after this Spanish flu. The systems were strengthened, research was strengthened. But this particular 2.5-year-old coronavirus yet to strengthen the health system, especially in developing countries. It has to really change the mindset of the political administrators that they have to really provide more budgetary provision for public health system. They should be really able to understand public health implementation is cost effective. It reduces the cost of the treatment at the tertiary healthcare level. And this is yet to happen in our own country also. We have been successfully handling these issues. But the public health system, I just want to tell you, the Tamil Nadu public health system, Maharashtra and Calcutta and Kerala public health systems are wonderful, even Gujarat. The same system should exist throughout the country. Delhi is also improving a lot. But the public health system, if it is improved, the surge of patients to the tertiary care level could be really reduced. That we have to bear it in mind, and we have to really lobby a lot with the political administrators, with the political parties, that more budgetary allocation has to be done for public health system for improving. Again, about the vaccination and the vaccine initiative, I worked for the vaccine initiative in WHO for some time, and vaccine initiative research also, India should really develop a lot. That is very, very important. I think the private sector collaboration also is very, very important. I am making a plea to the government. Why not the private sector be given a free hand on vaccinating people on charge basis, which will reduce the burden on the national government, and they can go for different vaccines from US or UK or anything like your Pfizer vaccine, all these things. We should have opened for the private sector to really work on that, which will really lessen the burden. Because in many of the states in India, the 50% of the healthcare system is done by the private sector. So the government should really think of hand-holding with the private sector to improve the treatment procedures and also reduce the financial costing for the vaccination and all, which is really spent for everybody. And the rich and the affluent can really get it done for the private hospitals. So again, the data management, I told you, data definitely helps you to take decisions. And public health people like me, we get the evidences from the laboratories, but we go ahead with the evidences and our experiences at the field level with the basic public health norms. That India should go ahead.
Yeah. Okay. Thank you. Here is a question for Dr. Venkateshan. Do we have a system in place to correlate clinical, demographic, and vaccine status information with infection? And, disease manifestation and virus sequence. Do we have a system in place?
Okay, so if you ask a systematic study of vaccination in a particular region or a population, and let's say the COVID infection, hospitalization, and death, the studies are actually going on. I mean, we have some preliminary results, let's say grosso modo results, but published papers are yet to come. It should be coming in near future. That's very clear. But if you look at, for example, the cases in UK and hospitalized numbers and death rate, or even in India, the cases, hospitalized rate and death rate, we can very clearly see the connection. But of course, in science, I mean, you just don't, you need to be a little bit more skeptical in looking at the numbers. I mean, that kind of papers are yet to come.
Okay, thank you. Now, I'll take a few questions from the audience. This is a question which has come on the YouTube, since we are streaming live there. Dr. Leria, you want to take this? It's been 2 years since the pandemic has begun. How important is to find out its genesis so that we minimize the chances of not being taken by surprise again?
Well, the short answer is that are we surprised by the pandemic itself? In my opinion, no. Because epidemics and outbreaks, epidemics and pandemics are reality. The viruses and bacteria, all pathogens have been on the planet for long. So first point is that we should be prepared for such outbreaks, epidemics and pandemic. That's one. And then we should be prepared to respond to them. Now, the tangential aspect is that, of course, we should know where a particular virus has originated. That attempt had been made. And in my opinion, of course, no matter what is the outcome of such investigations, it's always going to be controversial. There would be people who would come up with a conspiracy theory. So what I see that the effort bringing all the virologists, public health experts from globally, try to find out the answer. I'm not saying that they should not try to find the answer, but some attempt has been made. No matter what is the outcome, no matter what and how independent a committee say, in the years ahead, we would see movies and conspiracy theories and documentaries which will bring different aspects and say that this originated that way. So whatever is the final outcome, it will be questioned. I'm not I don't have an answer, and it's very unlikely that we know such kind of theories keep emerging. scientific community doing this process, it is not easy. And probably some virologists can only answer. But what majority of virologists are saying, beyond some of the conspiracy theorists or some of those who are saying that the gain of function research was being done in that particular setting, that's why it is originating. But we need to remember the gain of function, which result in increased virulence of pathogen, is a common research phenomena which is being done across the world. And because that happens, the conspiracy theories will exist. It's useful that scientific process followed, but beyond that, I would not be commenting or would not be worried. There would be people who would question whatever is out.
No, I do agree. I'm not going into the conspiracy part of it, but then we certainly know how it might have happened, how there could be one theory, genetic jumping, from its, jump from one species to another. And there are so many viruses carriers, which animals are carrying, birds are carrying around us. So the systematic study of where we are coming close, is there any indicator? And it's like saying that, I don't know when earthquake will come, but at least in the case of tsunami, you have early warning.
No, well, so the summary part is that, but this SARS-CoV-2, this particular virus, I believe that some answers are already there, and then there are some questions which are being further investigated. But what my broader point is that it will keep emerging. We know that in the current world, there is a more overcrowding. There are faster mode of transport, which essentially means that within 24 hours, a person from one part of the world, along with the pathogen, can travel to another part of the world. And by the time you recognize, you don't know what happened. The case of Omicron is a very good example of that. Then we also need to remember that the single animal livestock operations, where large number of the farming is being done with a single animal. We also know deforestation, which essentially means the viruses and pathogens which were in the forest are now coming in the human contact. We also know that climate change, which essentially means the temperature is rising, and the pathogens which would not survive in a particular setting will now start surviving and infecting human beings. So it is definitely more complex, and there are multiple interventions which are happening. And all of those points that we would have more outbreaks, more epidemics, and more pandemics. So the next pandemic would be closer than we can imagine. So more importantly, that we should be prepared. This is a nature and humanity together, and we need to be prepared for that.
Right. I think Dr. Venkatesan, you want to say something there?
Yeah, two things. One is such kind of huge pandemics with viruses and bacteria occurred when humans started agriculture and started to live in a single place. I mean, when you are living in a particular place. And with the growing urbanization, I mean, this is something that we should anticipate. We should expect that such a thing will happen and can happen virulently. That's one thing that we should plan for. That is where, for example, in India, there was a system of fever reporting. Disease reporting. Because until very recently, most of our medical care were within the public health system. There was a compulsory reporting from lower level hospitals to district level hospitals to state level hospitals to central, where you are monitoring what kind of things are happening where. If some unknown kind of diseases and unknown things are coming up in some place, you are able to catch it. In fact, within let's say within a month, even if in the beginning there was some dilly-dallying, that this pandemic was caught and found as a something unknown disease in China itself was because of some kind of a disease monitoring. So which essentially means even if in India the private medical care cannot be dismissed away in near future, okay, there should be some way of private medical care reporting people coming with diseases to them to some, that kind of surveillance system is necessary. That's
actually,
what this points to.
I think, sure, please go. Yeah.
Actually, in 1939, the British government has brought in notification system. In 1919, Madras City Municipal Corporation, the first government started by the Britishers, they have introduced the notification system. Unless and otherwise you keep a system of surveillance of the diseases at the primary health center level, you cannot really watch that. The best way is how really social monitoring should be there, how the surveillance system is going on. The national level database centers, private centers, also should take up that issue of monitoring the health status of the people day-to-day basis. The best place is primary health centers of the country. The primary health centers should be really acting as the surveillance centers to report about the illnesses, and we can easily identify much earlier before it becomes an outbreak of epidemic or pandemic. So surveillance system is very important, and that should be made known to several people. For example, IIT, Indian Institute of Technology, I have been requesting them for the past 20 years as a city health officer to collaborate with Chennai Corporation on disease surveillance. But now they come forward to do some analysis. So like that, these expert groups should really join hands with the government to do the surveillance and analysis so that we can foresee the epidemic outbreaks. That's what I want to say.
Yeah. Dr. Banerjee, it's a different question I want to ask you. We are seeing a sense of wariness with COVID, and this is actually a question which has come on YouTube from somebody. There's no name here. Many are psychologically giving up and are willing to take chances. How do you view this changing mindset? And this is important because at a time when many people are saying that, okay, Omicron is milder. In this context, how do you see this?
My take is that even the leading public health people, even all over the world, have said that Omicron will spread. Everybody will get Omicron, yes, whatever measures you take. Yes. Whether you do lockdown, whether you do masking, whether you do whatever you do. Because if you say this Omicron is very, very 3 or 4 or 5 times more transmissible than the earlier variants, we could not stop the earlier variants with all our restrictive measures. We could not stop Alpha, Delta, whatever variants we had. From China to Chandni Chowk, it traveled. So Omicron is going, everybody is going to get Omicron. That is we can say with 100% confidence that 100% people will get Omicron. So I think we should also examine and study the collateral damage of these restrictive measures and the fear, psychological fear, closure of schools, social backwardness of children, social trauma. It has fractured society. And many people will become obsessive compulsive, washing their hands, they are getting dermatitis and so many things. Definitely we have to take a pause and see what measures worked and what measures failed, and whether we have to continue. And particularly now when the news are coming that UK is stopped all restrictions. So people will get more wary here. What is wrong with us? Why we are having so much of restrictions? Why night curfew, day curfew, when it has not worked? And the lockdowns also, it is, so many things which have gone against science in this particular pandemic. Like lockdowns, say in our country, lockdowns, you put everyone in the house, our houses are very crowded. Had there been an office and vendors working in the street, outdoor transmission is not there. Indoor transmission is there. In the slums, in the tenements, you have put people together and you have closed the parks and playgrounds, and where the transmission was less. So naturally, people will get wary, and as it is Omicron, everybody is going to get it. No way you will be able to stop this virus. As I said, it will be one step ahead. It is like chasing the deer. So one thing what I can suggest here is, and there have been some people who have been suggesting, is you try to stratify the risk. Those who have got comorbidities, those who are vulnerable, those who are elderly, it will be focused prevention. And others, healthy and young people and students and schools, they can function properly without any restrictions. That would be the logical way to go forward.
Right. Dr. Mankrishnan, you want to say something on this?
Yeah,
not on this.
I think coming to the school closure, I think more than the public health measure, I think many governments are dragging their feet because of the public opinion. Just today, for example, the local circles have come out with a report, All India report. The parents unwilling to send children to school is in this third wave, even though the Omicron is mild and so on and so forth, is much higher even now, even though we are not peak. The reluctance level is much higher than the second wave peak from the All India survey. Of course, it's a representative survey. to the extent that it reflects broad mood. That's the broad mood that that is there. Perhaps the schools are closed not because of scientific reason, but because of the public fear, I suppose so.
Right. Now, Dr. Lahiri, here is a quick question. It's come from a YouTube comment from someone, Geeta. How long a vaccine will have its resistance power in the human body? Will there be any more booster doses to be taken? Of course, earlier you have cautioned, others have also spoken about booster doses and other things. Selective vaccination also been talked about, but here is the question. Yeah.
So the key is that this is a respiratory virus, and usually in the respiratory virus stage, one, they keep changing, and second is with the time immunity wanes off. So it is given that the protection with the 2 shots of vaccine would not be forever, unlike measles vaccine, other vaccines which you give. Now, the question arises, how much will be the risk when the protection decline? And that is the point which is going to determine that whether we need a booster or not. And then the risk, because we know the virus is going to be endemic, it will be keep circulating. But if it's causing only mild illness in majority, then they might not require a booster. But definitely high-risk individual whom there is a risk of severe illness would require booster. So we really have to wait for scientific evidence to know that what would be in the post-pandemic period, what would be the right interval for a booster, that's one, which will be the right vaccine for the booster, and which would be the target population which should be given a frequent booster. But what I foresee that for a healthy individual, it is going to be a choice which we make for flu vaccines, other vaccines. It is not going to be a requirement for it's going to be voluntary for everyone. For a healthy individual, it is not going to be that much a choice. But maybe for a few years, as long as virus is circulating till we understand epidemiology, the high-risk individual might require a booster, and that we have to wait. It will also depend upon which vaccines become available, which combination. So science will answer all of these questions. But I would say that as of today, we should not be too much worried. We should trust that whatever decision government would take will be fine, and then wait for it. Don't just rush for or wait that I'm waiting for booster or people are waiting for vaccination of children. There is no need of such things. Science is evolving. We are protected, and currently there is enough time before a decision on booster can be taken. It should be informed by the science and evidence.
Thank you, Dr. Lahiri. I think we are really running out of time. I'll quickly conclude, and then I want to thank all of you. The last 2 years of pandemic has taught many lessons to us. It has taught many new things. We are all exposed to more scientific and medical terminologies than we ever had. The speed at which the scientists globally got together and brought a vaccine is a phenomenon itself. In India, the vaccination effort on a large population is an achievement itself, which we have to really appreciate that. Over the last hour or so, we have heard a lot of reassuring words, optimism from all the experts here. But there are caution as well. The battle with the virus is far from over. While we go about our lives normally, we still cannot let our guards down. I think that's the underlying message. I thank my panelists and the viewers for joining the webinar. Good night. Thank you.
Thank you.